What is the difference between DKA and HHS? Today we're going to go over all the differences you'll need to know about for your next nursing exam. Hey guys, my name is Will Kirkpatrick. I'm a nursing educator inside Coursera, and today we're going to go over the difference between DKA, so Diabetic Ketoacidosis, versus HHS, so Hyperglycemic Hyperosmolar Syndrome. We're going to get right into it. I don't want to waste any time, but make sure you guys download our pathophysiology concept map that is completely free on CorseraNursing.com. That template will allow you guys to take the notes that you'll need to know about for each one of these conditions and compare them in a more clear way. So these pathophysiology concept maps will allow you to categorize what we're going to go over in pathophysiology, signs and symptoms, risk factors and complications, those medical management, nursing interventions, and of course the nursing diagnosis. So throughout this course, we're going to do a direct comparison between DKA and HHS when we go through each one of these concepts. So first, starting off with pathophysiology. If you guys have watched one of my courses before, I really dive in heavy into the pathophysiology because I believe it's going to help you understand all the other concepts you'll need to know about during your nursing exam. Because as you know, these nursing exams like to throw scenarios at you. And these scenarios are going to pull all kinds of different concepts that you'll see on our pathophysiology concept map. So let's first start with pathophysiology. So the first thing I want you to understand with diabetic ketoacidosis is that it's more associated with type 1 diabetes. So type 1 diabetics are more likely to get DKA, and type 2 diabetics are more likely to get HHS. So type 1 diabetics are more likely to be your pediatric patients because type 1 diabetes usually has an early onset in life. Versus type 2 diabetes, of course, you can get type 2 diabetes at any time of your lifespan, but it's more likely to be those older patients. And of course, it's more associated with obesity versus what type 1 diabetes is not as associated with obesity, it's more hereditary. So I want you guys to picture these patients that type 1 diabetes, it's usually your younger patients, and type 2 diabetes, it's usually your older patients that are more obese typically. All right, so what is DKA? So diabetic ketoacidosis. So really the name tells you what it is. It is a patient with type 1 diabetes who ends up getting severe hyperglycemia and dehydration and ends up getting ketones, and those ketones are acidic. So diabetic ketoacidosis. So why do type 1 diabetics go into ketoacidosis versus type 2 diabetics going into HHS? Well, it's actually very simple. If you guys remember, type 1 diabetics, they have absolutely no insulin production at all. So they rely on exogenous insulin, so external sources of insulin, because their pancreas is not making any insulin. So when there is an increased demand of blood sugar, so our cells have increased demand of sugar, well, when there's absolutely no insulin production, it ends up digesting fats instead of carbohydrates. So it ends up digesting fats and turning it into glucose in our bloodstream, so that way we do have blood sugar. But when we digest fats, it ends up producing a byproduct called ketones. So ketones are built up in our bloodstream because it's now digesting fats instead of the natural carbohydrates because there's absolutely no solution because there's no insulin. So when we digest fats, it produces ketones, and ketones is a byproduct of that fat metabolism, and it is very acidic to the body. So when ketones build up in the body, it actually triggers the renal threshold, so our kidneys. So when that is triggered, the kidneys then increase the amount of fluid loss. So you're going to be urinating more, and through that, you're going to spill bicarbonate. And if you guys remember, bicarbonate is the alkaline balance of our body. So when we spill that, and then there's also an additional on the other side, increased ketones, which is what? Acidic, it can cause metabolic acidosis. So in diabetic ketoacidosis, we have a triad of issues. Number one, we have dehydration because our kidneys are triggered and they're going to have a lot of fluid loss and we need to replace that. Number two, hyperglycemia, because what's the originating issue is because we don't have any insulin. And what's insulin's job? Insulin's job is to transport blood glucose to the cell. Well, the cell is now realizing that there's no glucose coming to them. So they're going to compensate and say, hey, we need to start breaking down fat. Well, unfortunately, when you start digesting fats, it's going to create a byproduct called ketones, and ketones are very acidic. So that byproduct is going to trigger the kidneys and increase the amount of fluid loss through those kidneys, and then also increase the spilling of bicarbonate. So here's your triad of issues. You got hyperglycemia, you have dehydration, and you have metabolic acidosis. All right, so let's go over to hyperglycemic hyperosmolar syndrome, so HHS for short. So once again, HHS is more associated with type 2 diabetics. And if you remember the pathophysiology of type 2 diabetes, it's different than type 1 because type 2 diabetes does not have an absolute absence of insulin like type 1. Type 2 diabetes, you can either have a decreased production of insulin, so your beta cells in your pancreas are still producing some insulin, or you can just have an increased resistance to that insulin transportation of blood glucose into the cell. So DKA is much more rapid onset because it can happen all of a sudden because we don't have any insulin, versus HHS is more of a progressive style of complication of diabetes because there is some insulin still left there, which is why they don't actually produce the ketones like type 1 diabetes, because producing ketones or digesting fats is pretty much like a last resort. There's absolutely no insulin, and our cells need glucose fast. So that's why type 1 diabetics go into DKA and type 2 diabetics go into HHS, because they don't necessarily need to do that last resort like DKA. However, HHS can be actually a bigger problem because, once again, these patients are more of a progressive onset. So when there is a long-term production or increased production of insulin, like in type 2 diabetes, where there's an increased demand of insulin all the time because there's either increased resistance or there's just a decreased ability to produce more insulin. So when there's a constant production of insulin going on in our bodies, that is of course going to tell our cells to be less sensitive to that insulin production. So when there's an actual huge need of insulin, it's going to have a harder problem of allowing insulin to transport glucose into the cell, which causes profound hyperglycemia versus DKA, where it's hyperglycemia, but in HHS, you're going to have a profound hyperglycemia, sometimes, a lot of the times actually, reaching over 600 milligrams per deciliter, where DKA is reaching around 250 to 500 milligrams per deciliter. So since we have a huge issue of the actual insulin receptors being so insensitive to that increased insulin production, that blood glucose is sitting and getting extremely high in that bloodstream, which makes the blood super thick. All right, so what happens when there's increased glucose in the body in general? Well, that's also going to trigger the renal threshold once again. And that's why we have something called polyuria. So just like how DKA gets triggered and it starts losing fluid, well, same thing in HHS because there's a profound increased amount of blood sugar. So it's going to trigger that renal threshold and cause our kidneys to spill lots and lots of fluid, which is what is called hyperosmolar, because it's going to cause osmotic diuresis, which is just the fluid, not the electrolytes. So we're also going to have a huge buildup of electrolytes, which is by definition hyperosmolar. Hey guys, it's Wilker Patrick, nursing educator inside Coursera. I wanted to let you guys know that I will help you with anything you need at any time if you just send me a text at 940-218-4062, 940-218-4062. Let's get back to the video. So HHS also has a triad of issues. So it is, once again, dehydration because they're losing so much fluid, and 2, extreme, profound hyperglycemia, so over 600 milligrams per deciliter, and then hyperosmolar, so increased lots of concentrated electrolytes in the bloodstream because there's so much fluid loss because it's osmotic diuresis due to that high buildup of blood sugar. All right, so let's do a recap. So the pathophysiology of DKA. So DKA patients are typically type 1 diabetics, which have absolutely no insulin production. So when there's an issue, so an increased demand of insulin, so that way the blood sugar can go into the cell, so the cell is super hungry for glucose, well, there's no insulin to transport that glucose into the cell. So what do our bodies do? Well, according to our cells, we have absolutely no blood glucose. So we're going to digest fats to make sure there is blood glucose in the vascular system. So what happens when you digest fats? Well, when you do that, it produces a byproduct called ketones. And ketones are super acidic. So those acidosis that is building up in our bloodstream triggers the renal threshold in our kidneys to produce increased volume loss. All right, so it gets rid of the volume, and then it also, in return, spills bicarbonate out of those kidneys as well, which leaves our body super acidic. So you're going to have 3 issues with diabetic ketoacidosis. Of course, hyperglycemia, between 250 to 500 milligrams per deciliter. And then number 2, dehydration, because you just lost so much fluid due to the ketone buildup, and you just lost so much byproduct of bicarbonate. And then lastly, you're going to have acidosis, specifically metabolic acidosis because you're losing bicarbonate and you're increasing the amount of ketones in the blood, which is, of course, naturally acidic. And HHS. So, HHS is associated with type 2 diabetes patients. And that is a more progressive and slow onset compared to DKA. So, that progressive and slow onset produces a chronic insulin resistance because there's so much insulin being produced all the time, so that way that blood glucose can get into the cell. So when our cells actually do need lots and lots of blood glucose to function, there's going to be an issue because there's resistance that has built up over time. So our bodies are going to try to produce more insulin, but it's not going to be going anywhere. It's just going to sit in that bloodstream, and it's going to profoundly increase the blood sugar. Well, that profound blood sugar that's building up, typically over 600 milligrams per deciliter, will trigger the renal threshold, and the kidneys will start losing fluid, specifically fluid by itself, which leaves the bloodstream super hyperosmolar, which is, by definition, increased concentration of electrolytes. So your three issues with HHS is hyperglycemia, so profound hyperglycemia, profound dehydration, and hyperosmolar. All right, let's move on to signs and symptoms. So the signs and symptoms always reflect back on the pathophysiology. We just dived pretty deep into the pathophysiology, so that way if you understand that, you're going to understand all the other concepts we're about to talk about. So signs and symptoms, risk factors and complications, and even in the interventions, if you understand pathophysiology, you're going to understand all the rest of this because it's going to make sense. So let's first just start out with the diabetes symptoms. So forget DKA and HHS. Well, these patients naturally have diabetes to even get these conditions. So let's talk about those. What are those? 3 Ps. I want you guys to remember polyuria, polydipsia, and polyphagia. Polyuria is increased amounts of urination, polydipsia is increased thirst, and polyphagia is increased hunger. Why, you might ask? Well, if you guys remember, if there's an increased blood sugar in the bloodstream, it triggers that renal threshold, which is what? That's when the kidneys start losing fluid. So when we lose fluid like that because of the increased blood sugar, well, it's going to naturally trigger our thirst receptors. So we're going to have increased thirst, so polydipsia. And then polyuria is because of the increased urination from the high blood sugar. But why polyphagia? Well, if you guys remember, those cells are needing blood sugar, and that insulin is not really able to function properly because there's either increased resistance to that insulin or there's a decreased production of insulin from the pancreas. So there's more blood sugar sitting in there, and the cells are actually starving of glucose. So that also triggers us that, oh, we need to eat because we have, they think, a low blood sugar. So we need to have more intake. So that's why they get polyphagia. Now let's talk about the differences between DKA and HHS signs and symptoms. First, starting out with DKA. So diabetic ketoacidosis. What are your signs and symptoms? Well, first of all, if we remember, it's hyperglycemia. That's your main sign and symptom. It's a hyperglycemia between 250 to 500 milligrams per deciliter. The number one thing that they love to ask about in the NCLEX and the nursing exams is the association with Kussmaul respirations. What is Kussmaul respirations? It's a rapid and deep inspiration and expiration that is associated with our bodies attempting to get rid of acidosis. So if you guys remember, diabetic ketoacidosis is a buildup. One of those triad issues is the metabolic acidosis. So there's a buildup of acidosis in our blood, while our lungs can compensate by trying to blow off CO2, which is what? Acidic. So it's getting rid of more acidosis in our body by increasing the respirations. So our body's going to compensate by increasing the respirations with a rapid and deep inspiration and expiration. So think of Kussmaul respirations as if someone's working out, but instead they're just sitting there in bed, they're not exercising, but it looks like they're breathing like they're working out. Another one is fruity breath. So you can actually smell the fruit in their breath, which is what? Ketones. Ketones are naturally a fruity smell. So you're actually smelling the ketones, the acidosis, leaving their body because they have Kussmaul respiration. And what's another triad issue they have? Dehydration. And what signs and symptoms does dehydration produce? Well, you're going to have low blood pressure, so hypotension, and then tachycardia because our heart needs to now pump faster to get the blood flow out because there's decreased blood pressure and there's decreased volume in the vascular system. And as you can assume, ketones are not very great for the brain as well, so you're not going to be surprised when you see confusion or just increased fatigue in general because of the increased respiration. All right, let's talk about HHS signs and symptoms. So number one, a profound hyperglycemia. They love to use the word profound on the NCLEX and your nursing exam, so pay attention to that. A profound hyperglycemia with HHS that is typically over 600 milligrams per deciliter. Another key one is severe Dehydration. So a lot of the times I like to use dry mucous membranes as a sign and symptom of severe dehydration. And of course, once again, hypotension and tachycardia. These patients are severely dehydrated. And another NCLEX tip they love to ask about is a lot of the times, since these patients are typically older, we talked about, remember, type 2 diabetics, it's usually the older generation with type 2 diabetes. Well, mental status changes is typically one of your first signs and symptoms. Why? Well, if you have an increased concentration of electrolytes, one of those electrolytes is sodium. So you could potentially have hypernatremia, which anytime there's an imbalance of sodium, it can cause confusion. So this is one of the big signs and symptoms they love to ask about as well. So make sure you guys write that down. All right, now talking about risk factors and complications. First, talking about risk factors. The number one thing that you guys need to remember for both DKA and HHS is that infection is the number one cause of these complications from diabetes. So think about it. What does infection do to our bodies? Well, it increases the metabolic rate naturally, right? It increases our temperature and it increases our metabolic rate. So what is a metabolic rate? Well, it's the demand of our cells to receive nutrients. So if you guys remember, what is the primary function of insulin? Insulin's primary function is to transport glucose to the cell. All right, so when we talk about how there was an increased need of glucose from that pathophysiology snippet we just did, well, if there's an increased need of glucose because our metabolic demand is up and we can't get the glucose, that's where you're going to have the issues. So that's a major risk factor slash cause of DKA and HHS. So really anything that could cause an increased metabolic rate, such as trauma as well, could cause these conditions. So that actually leads me to a very important concept that they like to reflect on DKA and HHS. So since infection is the number one cause of DKA and HHS, they like to reflect it in a scenario where that patient is sick. So a lot of times they reflect this back on calling it a sick day rule. So you need to know the sick day rules in relation to insulin and diabetes. The number one rule you'll need to remember is that you always give insulin even on their sick days. So even if they don't have intake, so if they're having trouble keeping food down, you still give the insulin, because remember the pathophysiology, guys, that increased metabolic rate is going to happen. There's going to be an increased demand of glucose. Well, if you stop giving insulin because of the concern of hypoglycemia, of course, then you're going to decrease the chances of insulin transporting glucose to that cell, which is what causes DKA and HHS. So one of the big things that the NCLEX and the nursing exams like to ask is if, oh, should you stop insulin on their sick days? No, you should absolutely continue to give insulin as prescribed, or of course call your physician to see if there needs to be an adjustment to that insulin administration. So even if that patient has a change of appetite or they're having trouble keeping food down, you still continue giving administration of insulin. And if the patient is type 1 diabetic, you want to start checking the urine for ketones, as that's one of the signs of diabetic ketoacidosis. And you want to encourage them to intake a lot of fluids because what? They're both at risk for severe dehydration. And number two, you want to keep them on the same meal plan as possible. So small and frequent meals to try to keep a consistent blood glucose intake. Now going over to complications. So let's first start with diabetic ketoacidosis. So the big complication that you want to look out for is related to dehydration. And of course, that's tachycardia and hypotension. But another one that's really important to remember, and the NCLEX loves asking about this as well, is the association with potassium. So potassium, it likes to react to the insulin. So insulin also not only helps glucose get into the cell, it also helps potassium going into the cell. So when there's a lack of insulin, it's going to lack the ability of potassium to go back into the cell, which is naturally its home. It's an intracellular electrolyte. So when there's an inability to get potassium into the cell, you're going to have increased potassium in the vascular space that can't get to the cell. So it's going to be hyperkalemia. So hyperkalemia, what does that cause? It can cause cardiac arrhythmias. Now it starts getting a little tricky. One of the management that we'll get into is administering bicarb, because we're spilling bicarb with diabetic ketoacidosis. So we need to administer bicarb to make sure our body doesn't get too acidic. So when we administer it, it allows the potassium to get put back into the cell, which can leave our bloodstream low in potassium. So it could potentially even cause hypokalemia. So it just depends on where you're at in management on what side of potassium you could potentially be at in regards to diabetic ketoacidosis. So either way, you want to look out for cardiac arrhythmias. And just a little side note with the potassium, hypokalemia on the EKG is more likely to cause a low ST segment or a depressed T wave. And then there's hyperkalemia, which is a high potassium above 5, that can cause a high peaked T wave, which the NCLEX loves to reflect on. But either way, whether it's hyperkalemia or hypokalemia, they're at risk for a complication of a cardiac arrhythmia, because when there's an imbalance of potassium, potassium allows the heart to repolarize slash relax. When there's a lack of relaxation, our heart can cramp up, and that can cause severe ventricular arrhythmia. So it could potentially cause death if you don't pay close attention to it in these patients. And then there's HHS, which is the same thing. They can have electrolyte imbalances, such as with the potassium, but specifically, more importantly, with the sodium. So remember, we have hyperglycemic hyperosmolar, which means there's an increased concentration of electrolytes, specifically the sodium. So when there's a hypernatremia, it can cause cerebral edema. So the three major complications you'll want to remember with HHS is cardiac arrhythmias, hypernatremia, and cerebral edema. All right, so diagnostics for both DKA and HHS. So DKA, let's first start with that. If we remember diabetic ketoacidosis, there are three major labs that we want to look out for. Of course, number one, blood glucose, because we want to see what the actual glucose is in the bloodstream. And then number two is bicarbonate. Why? Well, because remember, the increased amount of ketone production in the bloodstream increases the spilling of bicarbonate. So we need to really look at and see how bad the metabolic acidosis is. So we typically take an arterial blood gas to see how bad the acid-base balance is, and then we're also able to see what the bicarbonate is in our arterial blood. So typically with these patients, you're going to see a bicarbonate level below 18. So that is just one of the diagnostic findings with diabetic ketoacidosis. So you're going to see an ABG that is metabolic acidosis, which is a pH below 7.35, and a bicarbonate below 22, but a lot of the times with DKA, you're going to see it below 18. And then, of course, you're going to have increased urine ketones as one of those signs and diagnostic findings with diabetic ketoacidosis. But in today's practice, one of the biggest measurements we have for diabetic ketoacidosis, and this measures the severity of it, is the anion gap. So the anion gap is actually sodium minus the combination of bicarbonate and chloride. And the more ketone buildup we have in our blood, the bigger anion gap we will have. So it's a pretty direct measurement of how bad the diabetic ketoacidosis actually is. So a lot of the times physicians will use the anion gap to see the status of how well the management is working. And then once again, guys, don't forget that diabetic ketoacidosis at first can cause hyperkalemia because the insulin is not there to put the potassium back in the cell. So we're going to have a buildup of potassium in the blood. But as soon as you give bicarb, it could potentially cause hypokalemia. So a lot of the times, we'll switch over to medications, is that we will give potassium slowly along with our fluids and insulin. But let's stop right there. This is one of the biggest concepts they love asking about on the NCLEX and the nursing exams, is the prioritization question of what should the nurse do first for a diabetic ketoacidosis patient? Is it administering insulin, or is it administering fluids, or is it administering bicarb? Your answer every time will be administer the IV fluids. So why, you may ask? Well, if you guys remember, one of the biggest ways that our patients could potentially pass away from diabetic ketoacidosis, and one of the fastest ways, is through dehydration, because it's going to cause hypotension, tachycardia, and you're going to have a buildup of electrolyte imbalances, which could cause fatal cardiac arrhythmias. So we need to prioritize administering IV fluids to reverse that dehydration, because it's going to get so bad and it won't stop until we actually fix the dehydration first. And by fixing the dehydration, you're going to improve the delivery of insulin when we start administering that. So number two step would be to start administering IV insulin. So the only IV insulin that we can administer is regular insulin. So typically these patients are on an IV insulin drip that is checking the blood sugar every hour to see the status of that blood glucose. Now, we want to make sure we're not lowering that blood sugar too fast, because of course, if they're on an insulin drip, one of those risk factors is hypoglycemia, which is never good when a patient just came from a diabetic ketoacidosis. So that is why we check it every single hour, and we want to make sure we're giving just the right amount of insulin and not decreasing it too fast. So a lot of the times we will start with just normal saline IV fluids to start and get that fluid resuscitation back and prevent the dehydration. But after some time, to a certain level, and this depends on hospital policy, is that we will switch the IV fluid to a dextrose fluid, such as like a D5W. And we do that so that way we can balance the insulin administration along with controlling the blood sugar by preventing hypoglycemia. And if the bicarbonate is severely low, we will directly replace it with bicarbonate, but as soon as you do that, you got to start watching out for hypokalemia. And same thing with insulin. As soon as you start giving insulin, start watching out for hypokalemia, because now you're increasing the delivery of insulin to go into the cell. So you're leaving the bloodstream low on potassium. So you want to, typically, they will order an administration of potassium slowly along with the insulin administration. So what are your major nursing interventions? Is, of course, monitoring that blood sugar hourly. That is a common question with the NCLEX and the nursing exams. You want to monitor it hourly as long as they are on an IV insulin administration. Number 2, monitor for your complications, such as those fatal cardiac arrhythmias because of the potassium. So monitor the EKG, monitor your intake and output, a strict intake and output, and measure the weight daily. And of course, since these patients are typically having Kussmaul respirations, to get rid of that acidosis, you want to address respiration. So a lot of times they will need some increased oxygen supplementation due to the rapid respirations. All right, now starting with the diagnostics of HHS. So once again, guys, that number 1 trait is a profound, keyword, profound hyperglycemia, which is above 600 milligrams per deciliter. That's one of your biggest diagnostics. And then the other one, it's in the name, hyperosmolar, is your osmolality. So your serum osmolality in the blood, it's typically above 320. And then it wouldn't be abnormal to see hypernatremia and hyperkalemia once again at first until you start administering insulin, where you could have a hypokalemia. All right, now moving on to medications. Once again, your number 1 priority is to administer IV fluids first and then address the insulin. So we explained it just like how we did with the DKA. We're doing the same thing for HHS. Administering fluids is the priority, and then you get them on an insulin drip, once again, just like DKA, where you monitor the blood sugar hourly, and they're on a regular IV insulin drip. So your nursing interventions, once again, guys, is hourly blood sugars, strict I's and O's, daily weights, address the respirations, and of course, watch for cardiac arrhythmias due to hypokalemia. All right, guys, that sums up DKA versus HHS. I hope this course helped you guys out, and I look forward to seeing you guys in the next video. Hey guys, first of all, thank you so much for watching the video entirely through. It makes our day if we know that nursing school got a little bit easier after watching one of our videos. If you guys like this video, make sure you like it, subscribe to the channel for more, and drop down in the comments for any more ideas that you need help with nursing school. If you want to contact me personally, it's 940-218-4062. Thank you guys for watching. We'll see you in the next video.